Bowel endometriosis is a quite a common condition when it comes to hospitals like Chelsea, where we are a tertiary referral hospital. We know that about 20% of women suffer with endometriosis, and out of that 20%, about 2 to 3% of that category where they will have bowel endometriosis, and within that they will suffer with severe rectovaginal disease, which means disease which is affecting the back of the vagina and going into the rectum and bowel. And this problem can really increase in its intensity, causing a number of issues. I will just start with very simple themes and then we build on them towards bowel endometriosis. What is bowel endometriosis? We know that there are so many theories about it. We're still learning about it, what it is, even though such a long time we have been dealing with this disease. The most common way we think that the endometrium lining, these endometrium cells, implant comes out through the fallopian tube into the abdominal cavity, peritoneal cavity, and they implant themselves into different structures like bowel, bladder, peritoneum, ovaries, fallopian tubes, and even other structures as well. And wherever they implant, they cause adhesions and scarring, leading to pelvic pain. But there are so many other ways as well to look at it. And this picture clearly shows you that the lining of the womb breaks down and the endometrial cells comes in, the back of the vagina and rectum is just a very natural place for these cells to gravitate to. That's where they come in and settle down, and obviously on top of the rectum they start to go inside the rectal cell. And this picture will give you more idea. The rectum is just sitting next to the cervix and the uterus. So if anything is growing outside the uterus, the very natural place to grow is next to it is bowel, and hence it becomes such a common issue. Now we know that along with the implantation theory, we also know that we talk about metaplasia, we talk about maybe it goes into different parts of the body through blood and lymphatic system. We also think that there could be other way as well, that we have stem cells in the pouch of Douglas, in the area behind the uterus and between the rectum, and the cells start to differentiate, start to change into endometriotic cells and lead to these kind of adhesions. And obviously nowadays, more and more, we're talking about immunological factor. And maybe that's the thing where the future diagnosis and treatment will come from. So in brief, there are so many ways that we can explain why endometriosis grows, and then obviously involve the bowel. When it comes to bowel endometriosis, patient can present with a variety of symptoms. It can range from abdominal discomfort and pain to nausea, bloating and gas, severe intestinal cramps and pain, pelvic pain during sexual intercourse, constipation and diarrhea becomes a common symptom, alternating bowel symptoms is a big issue, painful bowel movements, rectal pain. So really it's a range of bowel symptoms which people will present. And that's actually brings a challenge, because challenge is that so many people will have these generalized bowel symptoms, but who is the one who actually have endometriosis? We know that endometriosis overlaps with so many other diseases. And if I want to pick up a common one, irritable bowel syndrome. So much has been written and searched about it, that how we can differentiate between irritable bowel syndrome and endometriosis, because most common theme is that when we go to our GPs, we go to our initial contact, we talk around about it, then the most things comes in, maybe it's irritable bowel I have because I'm suffering with constipation, suffering with diarrhea. But then again, who are those people who actually have endometriosis? And I will come to that question. But picking the right one is the challenge for all of us to get it. When we look at other causes of pelvic pain, this bowel pain, then irritable bowel syndrome, appendicitis, colitis, colon cancer, Crohn's, inflammatory bowel disease, all these things will come in the differential diagnosis, which doctors have to look at and differentiate that. When someone has these symptoms, bowel symptoms, then what they should do? The very simple thing is they will obviously see the GP for help. But I will tell everyone listening that keep a diary of your symptoms. Your diary is the key to help us to get to the diagnosis. We have a two-way job. We have to tell our doctors, and when I say doctors, all specialties from GP to surgeons to other specialties as well, that when someone comes with these kind of symptoms where you think about other bowel problem, do think about endometriosis as well. So keep a diary. It is really helpful for us. And obviously, once you see your GP, and we'll expect your GP to do a referral to hospital to an endometriosis specialist. And we all know that it is not an easy thing. The one study from Surrey showed us it takes on average 7 to 9 years from a GP to get to a tertiary hospital to be seen by a specialist endometriosis. This is very difficult, but that's where all the education, all the efforts by organizations like Endometriosis UK come in really to help with this journey to make it shorter. And at the early stage, dietary modification may have their role as well in these things. The only differential I will try to bring in before moving on to next stage is irritable bowel and endometriosis, because there is so much overlap between these two things. And I'm sure when Ollie speaks about it, he will tell us more about it. But an irritable bowel syndrome, it mostly affects the large bowel. Bloating, constipation, diarrhea, cramping, pain are common thing. But the one thing will be there, this is acyclical in nature. There'll be no pattern with periods. Having said that, we also know in some, about 20% of the patient, there will be overlap. There will be cyclical as well. They will say, when my period comes, my irritable bowel symptom like bloating pain gets worse. But mostly it will be acyclical, especially in the early stages. Straining, urgency, incomplete evacuation, mucus in the stool, all those things are mostly denoted to irritable bowel syndrome. When it comes to endometriosis and how to differentiate it, that mostly endometriosis symptoms are predominant with cyclical symptoms. My pain comes when I have my period. And I was just talking to a patient a few days ago. She told me that her pains were so bad that when her periods will be coming, she will stop eating, because she will be worried that if she eats, then she won't be able to pass stool because it's so painful. And she kept going to doctors. And the only diagnosis she had until the age of 30, irritable bowel syndrome, until someone put a sigmoidoscope, and saw the lesion coming through the bowel and diagnosed it as rectovaginal endometriosis. So it can be really difficult. So cyclical symptoms are a key to endometriosis. You may get sharp pain when you're evacuating the bowel. Painful intercourse can be a symptom. Pain passing stools and sharp pain while passing stools can be a symptom as well. And when the stools are evacuated, the pain gets better. So these kind of symptoms help us through your symptom diary to possibly come to the diagnosis early on. When someone has these symptoms, then the natural thing is that we investigate. Now, our investigation in hospital include, number one, an examination by an expert in a gynecology. Vaginal examination, rectal examination. Bowel endometriosis is one of those that if it's advanced, it can be palpated. With a finger, we can palpate. There is a nodule there through the rectum or through the vagina, which is palpable. And as you touch it with your finger, someone says, oh, it's very severely painful. So we just know that's possibly the nodule, which is palpable, which is so painful. Ultrasound scans are absolutely very important, and their sensitivity, their importance is increasing now because they're becoming better and better in diagnosing rectovaginal endometriosis, or in commas, bowel endometriosis we're talking about. MRI scan is a very common tool and very sensitive as well to diagnose bowel endometriosis, and especially the nodular lesions. Sigmoidoscopy, once we see them, they go to colorectal surgeon in a multidisciplinary care, and sigmoidoscopy is the one as well. However, the challenge in sigmoidoscopy is that this endometriotic nodule, which grows from the uterus through the outer bowel wall into the lumen of the rectum, it kind of doesn't penetrate through the mucosa in most of the cases. In many cases it do, but in most cases it does not. So it will involve the bowel, it will involve the muscularis, the muscle tissue of the bowel, but it will not penetrate through the bowel. So if I'm putting through the camera, I may not be able to see it. So not seeing it through the camera, sigmoidoscopy, colonoscopy does not rule out endometriosis as such, because we may still have it, and where MRI scan and our examination will help us. And the main thing that we are all focusing now is multidisciplinary care. That's the key. That's the key for the safe and better care that I speak to Oliver. Oliver speaks to me. We speak to urologists. We speak to pain specialists. And when everyone talks together, we come up with a better solution while we have these investigations in front of us and a better management plan. When it comes to treatment, the few slides I will show you, one is a holistic approach, medical treatment and surgical treatment. But whatever treatment we do, the principle of that treatment for us is when somebody we see, and again, you go there as a patient as well, that our theme should be that you are at the center of care. 1. 2, whatever we do, patient's expectation and goals must be the key of that management. And we should treat the patient, not the disease. That's very important. I'll come to it why I'm saying that we should treat the person in front of us, not the disease, but we are trying to deal with it. And when we're dealing with women, we should think about fertility, quality of life, psychological implication. Obviously, there's no time to go into it, but no day goes by when I see people with a huge psychological stress, what they've gone through from their very young age to the age when they get to somebody to have the treatment. And then what are the coping mechanisms? Yes, surgery is one of the tools. Yes, hormonal treatment is one of the tools, but dealing with the pain, dealing with stress and anxiety is far bigger than these things. These can be the tools to achieve that objective, but that objective may need much more things, from clinical behavioral therapy, how to manage pain, and how to manage anxiety and stress. And when we are seeing the endometriosis patients and surgical patients, the one thing I tell all my colleagues and our trainees, that we are dealing with younger generation, young patients, mostly in 20s and 30s. Fertility is, most of the time, is on their mind. It's a benign surgery. It's not a cancer where I just say, cut it out, do this, it'll sort it out. No, it's a benign surgery. We need to be very careful. This surgery is associated with complication, which will come to the discussion, which we'll do in the next few minutes now. And the other principle will be that whatever the disease it is, bowel endometriosis, we have to be radical towards that, but conservative towards its function. Very important. We should not do anything. We should affect the function of bowel, bladder, fertility, all those things. So it has to be very conservative and to respect the patient needs what they need. And these are the principles we should underline no matter what treatment approach we take. But that should be guiding all the doctors when we are talking to our patients. In holistic approach, I think the questions will come. It's a diet, exercise, clinical behavioral therapy, pain support. All these things do matter. Every single part of that do matter. The disease we deal with, we understand some of its pathophysiology and some we don't. We're still looking into, searching into it. So all those good practice things will come in detail later. We should be using these tools to help the symptoms. When it comes to medical treatment, it depends on patient choices. It depends if someone is trying to get pregnant or not trying to get pregnant. Our pain and quality of life is the main issue. That helps us to make the decision. Hormonal treatment, all of them are fine. There's a combined contraceptive pill. There are GnRH analogs like Zoladex. There are progesterone-only pill. So there are so many hormonal treatment, but our job is to sit with someone and to take through every single option, side effects, implications, and make a plan of care. But hormonal treatments are effective. That's the message. Hormonal treatments are effective. And there are some non-hormonal treatment as well. Again, we'll come down to laxatives or other treatment, which can help the bowel symptoms as well. Hormonal options are also good because it will treat all sides of the disease simultaneously wherever it is. It is ancillary benefit. It's a birth control as well. Generally well tolerated, relatively low side effects. Avoid the risks associated with surgery. Can be used in women who still have symptoms after surgery. It's quicker to access than surgery, especially long waiting time. I know how difficult it has been through the COVID time for the last 2 years now. Treatments have been delayed. People have been waiting for weeks, months, and maybe 2 years now to have this surgery done. So medical treatment is one tool to get through this difficult time while someone gets their surgery. And then it comes to surgical option, and I will leave surgical options only to talk about it. But it depends on, again, multiple factors and all those principles I laid out in my previous slides. And it's a multidisciplinary approach. I absolutely believe in it. There is, if someone says, I can do the bowel and I can do the bladder and I can do this, I will be very careful. I would like my colleagues to be with me who are doing nothing but bowel surgery every day. And if they're next to me, I feel very good. I feel very good for the patient because I know this patient will get the best care from the best hands. And there are so many ways to do surgical options. It's a shaving, it's disc, it's resection, but I will leave it again to Oliver to talk about them. And also, I'm sure the questions will come and we'll come to those answers. Thank you very much.
Thank you very much, Amer. And I'm going to ask you to stop sharing your slides and hand over to Ollie, if that's okay. Sorry,
hi there.
So.
That's okay. Hi there. You're hearing me okay?
Yeah.
Fantastic. Well, thank you so much for inviting me to participate in what is such an important webinar. It's a real privilege. And Amer has taken us through a sort of tour de force of bowel endometriosis. So I'm not going to talk for a great deal of time, but I thought it was important, and I checked with Endometriosis UK beforehand, that we perhaps just cover where I come in and the sort of conversation that you would be having with someone like me, were you to have to undergo combined surgery with an endometriosis surgeon such as Amer and a bowel surgeon such as me. So as Amer so rightly says, the first thing I always seek to do is to make absolutely certain that we're not dealing with any other pathology, because endometriosis is able to mimic so many other problems. And the commonest symptoms that we see in the colorectal clinic are often the commonest sort of symptoms that patients with endometriosis that affects the bowel might be experiencing. So those are things such as bleeding from the bottom, pain in the bottom, difficulty with bowel habit, irregularity of bowel habit, bloating, which is an incredibly difficult symptom to both define subjectively for the patient, but also for us to understand what it is that the patient's actually experiencing. So we take a detailed history and then move on to trying to make sure that we are certain what it is we're dealing with. As Amer says, the sort of cornerstone of that in the pelvis is an MRI scan. And looking at the MRI scan in conjunction with an expert radiologist in the multidisciplinary team meeting and with the gynecologist allows us to identify endometriosis in the space between the rectum and the vagina. What I find often is that some of the patients are surprised to realize quite how closely attached to each other those two structures are. And that's why if you get tethering from endometriosis in that space, that it can be very, very difficult. Our rectums act as a reservoir. When they fill full of feces, full of poo, they stretch, and that's their job. If, however, they are stuck like glue to the back of the vagina or the back of the cervix or uterus, and that tries to happen, it's incredibly painful. It gives you an urgency and a desire to open your bowels. And often one of the key parts of the history is hearing that once you then have opened the bowels, that pain has reduced somewhat. Not only do we use the MRI, though, often either during a first diagnostic laparoscopy done in conjunction with Amer, or prior to that in the endoscopy suite, we have a look inside either with a colonoscope or a flexible sigmoidoscope. As Amer so rightly said, it is quite unusual that we see full thickness endometriosis that has come all the way through all of the layers of the bowel to be visible to the colonoscope, because of course that scope is only looking at the lining of the bowel. If we do, it's still very helpful and we can confirm it with a biopsy. But often what I'm looking to do is to rule out other problems and causes, colitis, proctitis, polyps, cancers, things like that, because it's essential that if we're going to embark on surgery for endometriosis, we're doing so for the right reasons and not missing another diagnosis. One thing to perhaps warn some of the participants on tonight's webinar is that it's really useful to talk to somebody who's going to do an endoscopy on a patient with endometriosis beforehand and explain that you have endometriosis. Quite a few of these tests, particularly if it's a flexible sigmoidoscopy, which is a camera test of the lower half of the bowel, you don't give pain relief or sedation. And that's really difficult for patients with endometriosis because you suffer much higher levels of pain if you're having the rectum and the lower bowel distended with carbon dioxide or a camera pass through it. So I'm always really mindful that all of my patients with endometriosis or suspected endometriosis who are having an endoscopy have a consent and have an availability in our setup to have quite strong levels of sedation and pain relief whilst they're having that. We often do it with an anaesthetist present in the operating theatre. So once we have established the diagnosis, once we're clear that we're going to do an operation to clear endometriosis, there are three main options that you would be expected to hearing about in your outpatient consultation. The commonest and the one that has the least impact on the bowel is what's called a shave. That's simply shaving endometriosis off the outer surface of the lower colon, the sigmoid colon it's called, and the rectum. In the vast majority of cases, this is enough to clear the endometriosis. We do that in conjunction as a joint operation, myself and Amer or other colleagues. And because you're not penetrating the full thickness of the bowel, it's very unusual that you need to put any stitches in. We also use a flexible camera, a colonoscope during the procedure to check on the inside and the outside of the bowel, looking for any damage, any leak from the bowel And in the vast majority of patients, that's the commonest operation we do. Sometimes, however, the bowel is fully penetrated and a disc has to be excised. That's the second operation, a disc excision. Then you're left actually with a defect in the bowel, and you have to close that defect with some stitches. Finally, the most aggressive treatment, but one that we actually only have to do in a rare number of cases. So to try and put that into context, for every 10 patients that Amer and I would take to the operating theatre together, only one patient would we be expecting to have to do this. And that's to actually remove a piece of bowel. That operation is called a resection, an anterior resection. And it involves us then having to join the bowel back together. That increases the risk in any given operation, because when you have a join in the bowel, there's a possibility of the bowel contents leaking if it doesn't heal properly. And it's in this group of patients that we sometimes have to give a stoma bag. I always leave that to the end because that's the thing that people are most frightened about. But just to reassure you, rates of stoma formation in an expert centre such as Chelsea and Westminster are very, very low. I can't remember the last time we did a stoma for endometriosis. I think it was sometime in early 2020. And we haven't, in the 5.5, 6 years that Amer and I have been working together, ever had a patient left with a permanent colostomy. It's always been a temporary measure to allow things to heal and settle down, to often get a patient out of trouble. And then later on, I've been able to go back and do an operation to get rid of the stoma. So whilst there is often quite understandably stoma anxiety and stoma fear, the vast, vast majority of patients will never get one. And if they do get one, it will be a temporary matter. So in summary, before I pass it back to Emma and Amer, expect to make sure that other pathologies have been looked for and ruled out. Expect to have a consent process that is really detailed about what operation is planned and why. And finally, make sure it's really clear as to the extent of the operation on any given visit, and to have had a conversation around risks of stoma formation. I'll stop there and hand it back, and then hopefully some other questions will come in and we can talk some more.
Thank you, Oliver. Thank you, Amer. Very interesting. There are loads of questions, so we're not going to get through them all, but let's start off. And actually, one of the questions that we've had is around what is the recurrence of bowel endometriosis post-surgery? So if someone has surgery for endometriosis of the bowel, is it likely that it will grow back at some point?
Oliver, you want to take it?
Yeah, so it's a really good question. It's a really important question. Recurrence rates are quite low. It depends on which study you look at, but they're sort of normally around the sort of 5 to 20% mark. It does depend on how radical the initial surgery is. And I think that's a really important thing to consider, because as Amer was saying, it's about addressing the risk and benefit ratio. The more radical you go, the data shows the less likely you are to get recurrence. But you're also taking on extra risk in doing so, of damage to other structures, having a full thickness resection, leak, stoma bag, etc. So often Amer and I, when we're doing joint consent with patients who we're seeing before, we might say, well, look, what is it that you're willing to risk in order to try and get the benefit of complete clearance? And we will have discussions during an operation saying things like, we could go for that area, we could go and get that nodule, but actually in so doing, we might be having to do a longer operation, a more complex operation, and take on more risk. And therefore, let's see if what we have done for this benign condition is enough to cause significant improvement in whatever the aim is for the patient, be it fertility improvement, pain, dyspareunia, pain on intercourse, etc. Because we can always come back and take some more. Amer, I don't know if you think that's fair or right, or if you'd add anything to that.
You're absolutely right, actually. And if someone has a bowel surgery, and if a repeat surgery is one of that landmark, we can say is there to tell us if the recurrence happening, then we have never operated again on a patient where we have done the bowel operation. Having said that, patients will have some degree of symptoms. Endometriosis is a complex disease where it's involved the bowel, it involves other structures around, and there is a degree of adenomyosis in these patients as well. So some degree of symptoms will be there. And I always tell them, look, doctors can treat the visible disease. There'll be some degree of pain, anxiety, stress will be, which will be again dealt with a number of other things like hormonal treatments. And as we deal with young people, they go on to get pregnant, families and everything. So mostly these symptoms are very well controlled.
Thank you. And linked to that, one of the questions we've had is around if you've had bowel endometriosis, how likely is it you might get bladder endometriosis, and what would the symptoms be for that?
Right. So bowel endometriosis and bladder endometriosis are not directly linked as such. Endometriosis, when it grows outside the uterus, by those different theories I talked about, it can literally go anywhere. There is no linkage between bowel and bladder. But one thing we can say possibly that if someone has bowel endometriosis, which is a severe degree of endometriosis, then it's possible that this patient actually may be involving bladder as well. But the one thing which possibly that person may be thinking about, that we know that we have kidneys and the small tubes, ureter, come all the way from the back into the bladder. They actually pass very close to the rectum. And as the endometriosis grows into the rectal area, it pulls the ureter inside. So it's absolutely almost every single complex case we do, I need to have a camera inside the bladder, and I need to put a catheters inside the ureters to make sure that during surgery we do not cause any injury to ureter. And actually part of our process of surgery is to separate the ureters from the rectum so we can do safe surgery on the bowel. So bladder itself, but ureters are very closely linked with rectovaginal endometriosis.
And I think, I mean, one of the things I think as women, I've seen, when I've ever seen pictures of pelvis, they either have the reproductive organs or they have the bowel in, and actually it's all in there together. So it's quite a tight area, isn't it, that you're looking at in that one. A question, possibly for both of you, I'm not sure, is somebody's asked, the GnHR analogues are quite often recommended before bowel surgery. That's their question. And why are they recommended? Right.
There are many reasons for that. When we see patients in our clinics with endometriosis is a chronically, continuously evolving disease, spreading disease. We want to stop that process of continuous growth before they come for surgery. Most people who have bowel endometriosis, they also have endometriosis in the ovaries as well. Almost 80% of these patients who have bowel endometriosis have endometriosis in the ovaries as well. But GnRH analogs too, these injections like Zoladex, triptorelin, Prostep, and even combined contraceptive pill, they suppress the estrogen. And when the estrogen is suppressed, it stops or suppresses the glandular growth, the glands of endometriosis growth in the ovary, in the tissue. So everything, in a very simpler, milder word, it calms down everything. The things become easier for us to operate, less blood flow toward the structure. So when we are dissecting in those planes, when we are cutting through those planes, which actually have no normal anatomy anymore because of the fibrosis and scarring of endometriosis, this estrogen suppression by GnRH analog injection actually helps to reduce the blood flow and makes our surgery less invasive and less bleeding as well.
Thank you for that. We regularly get, and we've had some tonight, questions around, is there anything that those with endometriosis can do themselves in terms of diet or anything like that to help ease their endometriosis? Do either of you have any view on whether there is any evidence around if diet can help the bowel with endometriosis?
Oliver, you want to say something about diet?
Yeah, sure. So I am not aware of any good studies that show that there is a way in which certain dietary restrictions or exclusions can go on to help people with specifically the endometriosis related symptoms. Having said that, every patient is different, and there is often, as Amer put in his presentation, a very significant overlap between irritable bowel syndrome and endometriosis, and it can be an incredible challenge to try and unpick what is being caused by which of those conditions. And often I don't ever get a full answer until we've done surgery to eradicate the endometriosis, and you either get some patients saying all my bowel symptoms have gone completely, and you get other patients saying that it's made little or no difference to certain aspects of their digestion. So it comes down to things like Amer was saying, taking a diary of certain foodstuffs, and also some patients choose to trial certain exclusions. And I think that's fine, as long as you take a really clear diary and see whether or not it has any impact. But there is no specific advice I can give around, yes, all patients who have endometriosis in their bowel should cut out dairy or increase their fiber, because it'll be different for different patients. More broadly speaking, the advice I give all my patients, not just those with endometriosis, is around making sure that you have a well-balanced diet, making sure that you eat as much non-absorbable fiber as required to maintain a soft, fluffy stool. Patients with endometriosis more broadly will suffer more if they are severely constipated with things like rectal pain and anal pain. And so we don't want patients having to sit and push and strain and all those sorts of things. But beyond that, I don't have anything more specific.
Thank you. And I'm going to stick with you, Oliver, if I may now. I had a very specific question, is can the bowel become dependent on laxatives?
That is, oh gosh, I get asked that question a lot by a lot of people. So no is the sort of quick answer, in the sense that what I always worry about is that patients who benefit significantly from laxative use and where it improves their symptoms are in some way discouraged from this idea of bowel dependency or addiction. If you suffer with a problem with your bowel function, with it either what we call slow transit, so that you're struggling to go very often, or you're passing a very, very hard stool, and you take a laxative and it helps, carry on taking the laxative. It is far better that you have a better gut function, you're not in pain, you're not constipated all the time, and you're using laxatives than it is the other way around. That is slightly different to laxative abuse, which we see occasionally, often in younger women with other disorders around eating and diet and so on, in which case, with very, very, very high doses of regular laxatives, you can damage the bowel. But that is a sort of tiny little peripheral area. If in the vast majority of patients, there is a scenario in which you're taking laxative and it helps you, carry on taking it. And don't worry about taking it. There are plenty of patients I look after who take laxatives for their whole life. The final bit I'd say on laxatives is start with the softer, easier stuff, which is normally a type of fiber supplementation, things like Normacol or Fibergel or Movicol, rather than stimulants such as Senecot.
Thank you for that, Oliver. It's very helpful. One I think that is for Amer to start with is that someone's written that as part of your talk, you mentioned that bowel endometriosis is generally a sign that endometriosis is quite advanced. Is it possible to have only bowel pain and nothing else?
Most common symptoms we get with bowel endometriosis are quite advanced, but it's possible, absolutely. Then there's again the overlap of irritable bowel syndrome and other bowel symptom with endometriosis, and these will be milder symptoms. People coming to us and will improve with simple treatment, what just Ollie has mentioned. So yes, people can come in with generalized bowel symptoms and help with all those things which Ollie had just mentioned from the diet perspective and laxative perspective, and that's all what they will need. But they need a proper examination, investigation to rule that out, and then we go back to simple thing.
Thank you.
I would just add into that. I completely agree with what Amer just said, and I'd sort of add into that I would be, what's the word? I'd be slightly concerned if I had a patient whose only symptom package was bowel related and who had no gynecological symptoms at all, that endometriosis was a diagnosis. It's not impossible, but I think we would in our MDT look for other causes of the bowel symptoms before we attributed that, because it would be unusual to be so far advanced that you had bowel endometriosis and have had absolutely no problems with the gynecological organs.
Okay, that's great. Now you've just mentioned MDTs, and a couple of people haven't really heard of MDTs, multidisciplinary team meetings, I understand them. I don't know if you'd each like to say a little bit about how they're used to help manage patients.
Yeah, MDT is absolutely the central part of endometriosis care now in UK, since British Society of Gynaecological Endoscopy started that in UK and made it a part and parcel of any center who does tertiary level care for endometriosis. MDT simply means that as the disease goes by, it goes into bladder, into rectum, into ovaries and fallopian tubes, and even organs like diaphragm and eyes. because so many systems are involved and so extensively, it's not possible for one specialist to be able to manage all those various aspects, not only to, and even to make the correct decision, including fertility. For example, our multidisciplinary team has a fertility specialist who tells us, okay, this cyst is that big, she's that old, she wants to have children, and our next step should be to do a fertility treatment instead of an operation. So multidisciplinary team brings all the expertise together around the one table and makes the right decision for the patient. So it's like a center point for us. Oliver, you want to add something, being the part of the team?
Yeah, I'd agree with all that. I'm a bit of an MDT geek, in that I think they're a fascinating part of modern medicine, and they are relatively modern. They first sort of raised the term MDT, multidisciplinary team meeting, first raised its head in the sort of mid-1990s in relation to cancer care, and was part of the NHS's cancer framework document that came out in 2000. But most of the complex disease I look after is now run through an MDT. So be that, as you said in your introduction, Emma, all of our cancer cases are discussed in a multidisciplinary team meeting. All of our endometriosis complex cases are discussed in an MDT meeting. And so I run the abdo wall reconstruction unit here at Chelsea, and we have a team meeting. And it's what good care looks like. It's about seeing a patient from the different perspectives of the bowel surgeon, the urologist, the gynaecologist. And I can say I have learned more through being in those MDTs than I ever would looking after patients by myself. So I think, another take-home message from the webinar would be that I think most patients would expect, if they are having complex surgery or have complex or advanced disease, that they should have been discussed in an MDT, and that they should know what the basis of the outcome was, and the basis of the discussions was.
Thank you. Yeah, that's great. So hopefully that's answered the questions about MDTs. I think we're both very keen on them. So that's great. Thank you for that. One question we've had is that if endometriosis is found on one part of the bowel, how can a surgeon know whether or not there are other areas of endometriosis on the bowel?
That's a really good question, a really important question. So the commonest place for us to see the endometriosis is in the rectum and the lower colon, the sigmoid. And that's just the anatomical approximation of that part of bowel to the pouch of Douglas, which is the space behind the cervix and uterus and the back of the vagina. But the tests that we do beforehand, the MRI scan, is particularly good at looking at other parts of bowel, and then the colonoscopy. And then the final piece is that when we're doing the surgery, we're doing it laparoscopically. And what that allows us to do is to look around the whole rest of the abdomen. So the first part of the operation is actually a diagnostic step rather than a therapeutic step. It allows us to look at the rest of the colon. It allows us to look at the small bowel, the appendix, and then to look up at the diaphragm, the liver, and the gallbladder. So we get a good viewpoint, basically, of all of it. Endometriosis outside of the rectosigmoid is really quite unusual and rare. I've taken out a couple of appendixes with endometriosis on them, and I've removed 2 small bowel strictures from endometriotic strictures and fibrosis on the small bowel. But that is unusual stuff.
That's great. You just actually, someone did pick that up as a question. Is endometriosis on the appendix also classed as bowel endometriosis, or is that a different thing?
No, that's right. Yeah, the appendix is part of the large bowel. It comes off the cecum, which is the very first part of our colon. So that would be classified as the same.
Okay. Thank you very much for that. Also, some other questions, and again, we get it quite often asked this, is that is for those with bowel endometriosis, is it possible to have cyclical bleeding in your poo, basically? I'm sure that's a better way of saying that. But.
No, that's the best way of saying it, because then people actually know what we're talking about. That's another really important question, and I'm really glad it's got asked. Cyclical bleeding can come from endometriosis, but it is not the commonest reason for cyclical bleeding. The commonest reason is hemorrhoids. And that's because during that part of the menstrual cycle, so during menstruation, you get venous engorgement and a slight increase in the pressure of the venous system of the pelvis. And that increases the blood supply and the pressure within the blood vessels of the hemorrhoids. And we know that in all human beings, not just in women with endometriosis, that the commonest reason for rectal bleeding is hemorrhoidal bleeding. So I'm always interested in hearing about cyclical bleeding, but it shouldn't be attributed to endometriosis in the first instance. That would need you to have full thickness endometriosis, where the blood from the endometriosis is actually trickling into the colon.
Fascinating. Thank you for that one. Oliver, you did say that the bowel resections, where you end up taking a section of bowel out, is the rarest one that you see when you're operating, but we've had a couple of questions around that. And one of them is around what level of discussion would be had with the patient beforehand. And I suppose the concern is that people wake up with a stoma bag when they didn't know that might happen. Would you like to talk us a little bit around that?
Absolutely, yeah, no, delighted to. So waking up with a stoma bag when you didn't know it was going to happen should be close to what we call a never event, in that the patient should have been well consented and well prepared. Now, there are very, very rare occasions where someone might wake up from an emergency scenario to find that they've got a stoma bag when they weren't supposed to. But in a planned elective operation, that should not happen. And the reason why it shouldn't happen is because it should be explained in the preoperative process what it is that you're aiming to do and how far it is that the patient is willing to go to get rid of their endometriosis and their symptoms. So I'll sort of go to two extremes of the scenario to demonstrate that. We have patients who say, my endometriosis is absolutely ruining my life. The impact on my bowel function, the pain, the dyspareunia is ruining my life, and I will do anything for you to help me get rid of it. And in that patient, saying to them, right, well then, from looking at your MRI scan and examining you before, and often having done one laparoscopy with Amer together already, we think that the only way we can do that for you is to cut out a part of your bowel. And so we're going to do that, and then I will give a percentage. Normally, it's only around about 10% likelihood that after cutting out the piece of the bowel, I feel that you will require a temporary stoma bag. So I'll say, when you wake up, I will be there, and I will tell you whether or not I've had to give you one. But there's about a 10% chance that that's going to happen. At the other end of the extreme, you might have a patient who says, look, I just want to get pregnant. And if you see a bit of endometriosis on my bowel and it's easy and you can shave it off, that's great. But if there's any other risk, I don't want you to bother. Okay, I just don't need you to. I'd much rather be with the symptoms I've got now and avoid the risk. And in that sense, I say, okay, well, there is no step in which I'm going to get you to anywhere near having a bowel resection. I'm just not going to take that risk. We'll make sure the bowel's moved out of the way so that Amer can do what he requires to do, and otherwise we're going to leave everything alone. So it's all about the consent process beforehand.
That's great, thank you. Amer, I don't know if there's anything you wanted to add.
No, I think Ollie is absolutely right. We had patients who knew they have bowel endometriosis and symptoms as well, but their choice was to conceive and get pregnant and carry on. And we had a multidisciplinary meetings, talk to fertility specialists, their potential to get pregnant, AMH and all the blood tests and everything. And the decision was, okay, go in, do what needs to be done mildly. But if it's a big operation, then leave it for the time being. I want to conceive, I want to get pregnant. So it comes down to patient choices and their consent and us explaining them pros and cons of every single option.
Thank you. Now, this is a linked question, so you've sort of half answered it, both of you, I know, but some people saying if they have quite mild symptoms, but they're told they have bowel endometriosis, should they get treated or not? And I suppose the implicit in that is, can it progress or not as a disease?
Yes. So if I take it, if they have a mild symptom, but they have been told that they have a bowel problem, we do ask this question very frequently when we are examining them and investigating them. And it happens sometimes that patient has mild symptom came in with, when we examine them and scan them or MRI scan, we found they have a rectovaginal endometriosis, bowel endometriosis, while symptom mild. Again, we came back to the drawing board, consenting, we explained the patient. Now, there are patients who have decided after all the discussion, they will leave the disease as it is, and they will carry on until the symptom get worse, they will come back. Will disease progress? In my experience, yes, it will progress. The disease I see today with a big nodule going through the bowel obviously started to grow at some stage few years down the line, few years before. So there is an element of progression. If I leave a disease today, it will get worse. But again, it comes down to that discussion and consent process we have to do with the patient.
Oh,
Ali, you want to say something? Yeah.
Yeah, sorry. All I would add to that is, please remember this is a benign condition. By benign, we don't mean nice. It's a horrible, horrible condition, but it is not a cancer, and you can always do more surgery. It is very, very difficult to undo surgery. So if we are treating a disease predominantly to treat its symptoms, if you have little to no symptoms, most of the time, there are caveats, but most of the time our advice will be, don't do anything too radical. We can always come back another time. This is keyhole surgery that you recover from very quickly. It's perfectly possible to have a keyhole operation with Amer and I and we decide we're not going to do something. And then a year or two later, we decide that now is the time to go back a second time and do something more. I would much rather do that and feel much more comfortable doing that with my patients than I would feeling like we had to go, hell for leather at the very, very first opportunity.
thank you. Moving on to a slightly different topic, has questions around if someone is approaching menopause, is it likely they'll suffer with bowel endometriosis?
When it comes to endometriosis, it's mostly estrogen dependent disease in the beginning to start with. Estrogen is the one which grows the endometrial-like glands around the rectum, around the bowel, and it leads to that fibrosis, scarring, and all the symptoms we're talking about. As people go towards the menopause, these symptoms tend to get better because either the estrogen deficient state. So I will say, if patients have less symptom, then symptom eventually will get better, gradually will get better, and they will not need any much complex surgery if the symptoms are mild to start with. So answer is yes, symptoms should get better with menopause.
Thank you for that. Now we are coming up to the last 5 minutes, and so just another few people have asked, because we talked earlier about the use of laxatives, but some people have asked, can the other way, diarrhea, be a symptom of bowel endometriosis?
Ali?
Yes, is the honest answer. Yes, it can. It can. All I would add to that is that we're not very good, because we don't talk about poo and pooing very much in polite conversation, at being a bit more specific. And so diarrhea can mean two different things to different people. To some people, to most people, it means having a looser stool, so tending more towards a wetter, looser stool. But it can also talk about going to the toilet more often. And one of the symptoms that people with bad rectovaginal endometriosis often get, and for patients to be mindful of, is frequency of stool. So they might not be passing anything that's that watery, but they feel like they need to keep going to the toilet. And that's often because of rectal irritation. The rectum isn't as stretchy, it's a bit inflamed, particularly around the time of menstruating. And so the patient feels they have to go on a number of occasions to try and get an adequate defecation.
Great, thank you. Oh, sorry, just lost my questions here. And so somebody has asked, now I know that we've talked, Oliver, you talked about various things, but someone has asked if someone does have a bowel resection, and we have discussed that that's relatively rare, what's the recovery time for that? You maybe want to expand that to the other types as well of surgery.
Yeah, I'll bracket them together. Basically, if patients have just a shave, where we're taking off the outer surface, but you're not having to do any structural removal, then often those patients will go home the next day or the day after, when Amer and I operate together, so a 1 or 2 night stay. If a patient's having a disc resection, so there's an area of the bowel that full thickness has been repaired, that would still be the shorter end. But a full resection normally extends your length of stay out to, say, 4 nights, 5 nights. It's very variable, but it does elongate the length of stay because it's a bigger operation with more rest.
Yeah, great, thank you.
It's still in the vast majority of occasions, though, done as a keyhole operation.